Thank you for the introduction. Good afternoon, everyone. I will be presenting on the community-based interventions for newborns in Ethiopia randomized controlled trial. We have acronym it COMBINE. And this project is part of the Saving Newborn Lives program implemented in Ethiopia by Save the Children and funded, as you know, by the Bill and Melinda Gates Foundation. And I'll be making this presentation on behalf of all the big team members of COMBINE back home, and also some of them here who was part of the research design. So briefly, I'll take you through some of the data on neonatal survival in Ethiopia. Then we'll directly go into what the objectives of the COMBINE are, what the intervention entails, some of the lessons and the results we have so far, the opportunities and the challenges. To start with some of the newborn survival related indicators in Ethiopia, this you have been seeing it from other countries as well beginning yesterday. There has been a remarkable decrease in all levels of childhood mortality in Ethiopia. In fact, mortality rate reduced significantly over the 20 years period of the 3 DHS periods. Over the under 5 mortality reduced at the same rate, but neonatal mortality is reducing very slowly. And currently it accounts for about 33% of the mortalities. And again, when we look at the pace of the reduction, the 1 to 59 months reduction has been at 5.5% annually, but neonatal mortality rate reduction has been about half of that annually. And we have estimated 81,000 neonatal deaths on annual basis. And this you have also seen from yesterday's different presentations as well. The 3 major causes of deaths accounting to about 90% of the newborn deaths in the country are infection, intrapartum related, and preterm birth related complications. Looking at the service coverage trends, these are some of the service statistics I pulled from the 3 DHSs, the 2000, 2005, and 2011. As you see, there is some level of improvement in the different service areas, including contraceptive prevalence rate, antenatal care, and exclusive breastfeeding. But delivery by skilled birth attendants and postnatal care has remained very low over the 3 DHS periods. And to kind of give you a little bit background to set the stage for the country is very large with 86 million, about 86 million population. And about more than 80% of the population lives in rural areas. It has a very diverse geography with very low geographically, like at sea level, flat areas, and also high mountainous areas in the country. About 10% of the population in the country is pastoralist, and more than 80% of the deliveries happen at home. So you can see the low-skilled birth attendants coverage and postnatal care. So going into COMBINE, what were the objectives of the community-based interventions we are implementing? Given the majority of births happen at home with virtually no early PNC, the need for community-based strategy to address healthcare needs of neonates was very clear, and COMBINE was designed with this in mind, and also to address one of the major causes of neonatal mortality in Ethiopia. It focuses on infection. And the key objectives were, when it started, we had over 30% of the newborn mortality due to infection, and that was why the focus was also on infection. It is a randomized controlled trial. It has 2 arms, intervention and control. It's being implemented in about 660,000 population clusters divided into control and intervention. And it's designed and powered to measure impact on newborn mortality. And the key objectives were to measure impact on newborn mortality of one is when the strengthened health extension program is implemented in the country to address newborn care as per the government policy, which is assess, classify, and refer newborns and sick young infants to the next level of care, no treatment for sick young infants and newborns at community level. And the next objective is to manage newborn sepsis with antibiotics by health extension workers at the community level. To give you a little bit background of the health extension workers and the health extension program, because I will be in the subsequent slides talking about the health extension program. The health extension program is a key government vehicle, so to say, of delivering primary health care services close to the homes for the rural majority. It is a key healthcare delivery system at the primary healthcare unit level that provides a package of basic promotive, preventive, and selected high-impact curative services, including ICCM, but not newborn and young, treatment for newborns and young infants. And there are two health extension workers. These are high school completed girls who are trained both in theory and practice for 1 year and are assigned at a health post level to work in the community of an average of 5,000 population, and they are supported by what we call the Health Development Army. These are community members or model females in the community deployed to teach their neighbors in a 1-to-5 network and mobilize the community to improve health behavior and practices. And so this is a picture of a health post, a typical health post and the health extension workers, young girls. So what did Combine do? The key Combine interventions were basically two. One is strengthening the implementation of the health extension program for maternal and newborn care. This is already what the health extension workers are supposed to do, but we strengthened that program, which I'll elaborate in the next slide. And the second one is improve the health extension workers' ability to capture and manage cases of severe neonatal infections at community level when referral was not possible. So what do we mean by strengthening the health extension program under Combine? This is basically tightening the link between the health extension workers and this community health development army members I mentioned earlier. And it involves structured home visits during pregnancy and postnatal period. And in addition to tightening the link, it includes training of health extension workers and also this health development army, or we call female community health promoters or development team leaders, to identify sick young infants, strengthening the supportive supervision and mentoring of these cadres of workers after the training, ensuring availability of supplies, and also improve documentation and use of data at their level. So in terms of strengthening, the pregnancy home visit package includes 2 visits by the community health promoters, or these health development army members. 1 visit as soon as the pregnancy is identified, and 1 visit at around 8 months of pregnancy, and another visit by health extension workers. And these visits focus on counseling on benefits of antenatal care, recognition of danger signs for the mother and the newborn, birth preparedness and planning, essential newborn care, and notification of labor or soon after delivery for these volunteers or health extension workers. And in terms of the postnatal visit package, it's 2 visits by the health extension workers in the first week of postnatal period, on day 1 and day 4, and 3 visits by the health development army members in the first week, in day 1, day 3, and day 7. In low birth weight babies cases, 1 extra visit, and there is 1 additional visit also on the 29th day by these community members. And again, the package of this visit includes more or less the same: counseling and support for essential newborn care, assessing the newborn and mother for danger signs, referral for illnesses, and sepsis management of newborn by the health extension workers if referral is not accepted. This happens in the intervention arm of the study. So in terms of the community management, the second objective, the community management of newborn sepsis under Combine, it is based on identification of danger signs and when referral is not possible. So all identified newborn sepsis cases are offered referral at first, and when referral is not, because that is the government policy, and when referral is not possible, then the health extension workers will provide will treat the cases. And this is based on daily injectable gentamicin for 7 days, and twice daily amoxicillin at home by the mother for 7 days. And for very low birth weight babies, it is administering the first dose and refer to higher level facilities, to the next level facility. So the combined newborn sepsis management is based on what we call the 4Cs model, because of, as I mentioned earlier, a very high level of home delivery, low awareness of danger signs, and also low literacy, and a lot of seclusion of mothers and newborns soon after delivery. Home visits are very essential and critical steps for this program. And we use this 4C model. The first one is contacting all newborns. The contact means all newborns have early contact with health extension workers or the 1 to 5 network leaders. And then capture all cases of severe infection in newborns. These are identified either by the health extension workers, by families, or by the 1 to 5 network leaders. And then once identified, they are provided with care, which means antibiotic treatment as appropriate when referral is not possible, as soon as it's diagnosed. And then the 4C is completion of treatment, full 7 days course of antibiotics by the health extension workers. And as you see, this model is an integral part of the maternal newborn health continuum of care, because it starts from the pregnancy. It starts from identification of all pregnant women to make sure that we have contacted all newborns. We start from the identification and registration of all pregnancies, and then continues with antenatal care, counseling, and the things I showed in one of the slides in terms of the pregnancy visit. And then it includes immediate labor notification, early contact with all newborns, with postnatal visits. So it's part of the maternal newborn continuum of care. It's not a newborn focused intervention per se. So looking at a summary of the routine data, we haven't yet finalized the research. We are currently, as we speak, conducting the inline census survey, and data collection will be finished end of June. We will probably have some kind of preliminary report September, November, December, around the last quarter of the year. But based on routine data, this graph shows deliveries identified and postnatal visits within the first 2 and 3 days at that community level. And the expected pregnancy was determined based on the baseline data we collected at the start of the research. And as you can see from this slide, health extension workers and community health promoters were able to reach more than 80% of the pregnancies based on the expected pregnancy we determined earlier. And then they were also able to do postnatal visits within the first 2 days of life or the 2 days of after birth for about 80% or more of the cases. And this is pretty high level of coverage. And this one shows postnatal visits within the first week of life. As you can see, if they are visited within the first 2 days, I think that is pretty much what they can do. If they visit, they do it within the first 2 to 3 days. There is no increment we've seen or change we have seen over the 7 days period. So what is working? In terms of the lessons we got from the implementation so far, there is high level of pregnancy identification, notification of delivery, and conduct of early postnatal home visits by health extension workers and 1 to 5 network leaders. There is a good proportion of sepsis case identification and treatment, and very high level of treatment completion at the health post level. This is the data which I showed on the graph. There is also very high motivation of health extension workers to provide the services because they are primarily focused on prevention and promotion, and the addition of this in their package has increased their kind of respect within the community. They are trusted because they provide treatment for sick children. Family referral of sick neonates is there, and it shows us that there is improved awareness about neonatal danger signs. And male involvement is also there in changing some of the norms through community and religious leaders. These things are some of the lessons we have learned. In terms of the challenges, I mean, these are challenges you have been looking yesterday and probably from today's presentation. It's not very typical for Ethiopia alone. We see them in many other countries. From the demand side, there are cultural practices preventing families from taking newborns out of the home in the early period of their life, and that makes it very difficult for them to access health care. There is very poor awareness of newborn illness and its seriousness. There is also very low value or belief in the modern health care, especially for newborn illnesses. And from the supply side, these are the usual suspects: access-related barriers, human resources, issues related to logistics and supplies. What are the opportunities for scale-up? We have a very strong community platform. The health extension program is a huge platform we have currently. The health extension workers are government employees, salaried through the government system. We have over 35,000 of them everywhere in the country. We have implemented ICCM across the country, so the newborn sepsis management is going to be added on that, and the platform, we believe, has the capacity to add on this additional intervention. What is being done under the forces model is strengthening the primary health care unit, and that is critical to needed or one of the essential aspects of the health system at community level for effective referral and support. And in terms of the demand, we believe that the Health Development Army and the counseling by the health extension workers, since the Health Development Army is currently being rolled out, that has a potential to improve the demand. And as I showed in one of the slides, this is an integral part of the continuum of care. It's not really specific newborn sepsis management focused intervention. So the combined strategies fit very well into the government platform and strategy. So this has not been a parallel system, and that was not the intention even from the outset. So community management of neonatal sepsis has a potential to save many newborn lives in the Ethiopian context. That's what we have learned, and we can conclude from the combined study. And these are all collaborators. Thank you.